Okay, so we're going to continue our COPD lecture here. And right now we're going to focus on chronic bronchitis. You're going to see a lot of similarities, the signs and symptoms for chronic bronchitis and asthma. However, asthma has a genetic trait where chronic bronchitis does not. So with chronic bronchitis, we have exposure to an irritant. It triggers the inflammatory response. We have an increased mucus production, congestion, bronchospasms, impaired gas exchange. Our oxygen decreases and our CO2 increases. And the main instigator for chronic bronchitis, although not always, but the main instigator is smoking. So chronic bronchitis is chronic inflammation of the lungs. If someone smokes all the time or is always exposed to an irritant, then they're going to have chronic inflammation. So your bronchial walls thicken and stiffen on a constant basis. Your goblet cells are working overtime and producing really thick, copious amounts of fluid to try to rid your lungs of the irritants that are causing the inflammation. And because of that, we can get mucus plugs, which are basically mucus that is blocking the airway itself. This also traps the oxygen in the CO2. So we get CO2 retention and we get oxygen trapped as well in the alveoli. Due to the lack of oxygenation that's coming into our body, we are hypoxic. This stimulates the kidneys to produce RBCs, which is a compensatory mechanism. So you will see hemoglobin levels increase. A big difference with chronic bronchitis is cor pulmonale. So this is a complication. It is a fancy word for right-sided heart failure. The pressure actually increases in the pulmonary artery as the blood can't flow into the lungs from the heart because of the mucus. And so there's increased pressure in the right ventricle, and it stretches the right ventricle, which causes right-sided heart failure. So if our blood is flowing into our lungs through our pulmonary artery, it comes up against resistance because of the mucus. And so because of the resistance, then you get some backflow of pressure of blood into your right ventricle. This right ventricle enlarges, the muscle of the heart gets stretched and thinned, and then it is not as taut and it doesn't have as much pressure to pump the right ventricle. And so then you are left with right-sided heart failure. So treatment for chronic bronchitis is we need to loosen and liquefy the secretions. So we can do postural drainage, chest physiotherapy. The medications we use are the same as asthma, plus we use more mucolytics, so the acetylcysteine, especially if that mucus plug is up near the bronchial tubal airway. And we can use more guaifenesin as well, the Mucinex. What we don't want to do is we don't want to suppress their cough if they have one, because we want to try and get all the skunk out as much as possible, because then that will increase their oxygenation. If we do suppress their cough, a complication for chronic bronchitis is atelectasis. This is actually if we suppress the cough or not, is a complication. So basically, let's take a look at this big picture here. Atelectasis is when the alveoli collapse. You're not going to see much change from that. However, if we're looking at this tree up here and the mucus plug happens here, then this whole section of your upper lobe might be deflated. And then if we mucus plug this lower branch, this entire lower section will be deflated. And we can also have a plug right here at the bronchial bifurcation, and that would deflate your entire lung. Here's another view for you to look at. This is a mucus plug close to the bifurcation of your bronchial tubes, and this has deflated the alveoli in this area. So this section right here would be atelectasis. This is leaving a large upper space of lung cavity that is not being used. So decrease in lung capacity. This is another version. This would be compression atelectasis. If you have pneumonia and your lungs were starting to fill up with fluid, you could have pockets of fluid start to build up and compress against the lung. And this section here of the lung is called atelectasis because it is actually deflated. The compression is deflating the alveoli. So this is part of a collapsed lung. Okay. Pneumothorax would be this section right here, not the atelectasis. So if you have a trauma and your lung deflates, that would be a pneumothorax. But within the lung tissue, you would have atelectasis, where the pneumothorax has compressed the lung tissue. So let's talk about the respiratory drive with our COPD patient. So let's just say our patient for this slide has a normal oxygen saturation rate of 89%. But they come into the hospital because they have pneumonia or some other type of illness that is decreasing their oxygen saturation. If we increase the oxygen quickly and have the patient have an oxygen saturation rate of, let's say, 92 or 94 or 96%, that is going to decrease their respiratory drive. So if the patient comes in and they're 77%, you're not just going to give them 2 liters to maybe 82% and leave them there. You're going to give them more oxygen. You're going to increase it slowly to get them to at least 89%, which is their norm. If you do that, you will not decrease their respiratory drive. You could have that patient on a 15 liters non-rebreather mask. And as long as their oxygenation is just at 89, you're not going to decrease that respiratory drive. So the key with a COPD patient, again, is to keep their oxygen saturation at their normal level. The biggest thing you need to come away with here is if you have this patient and their oxygen level is 94 and they're normally 89, we need to decrease that oxygen flow rate.